Dear students, today we will discuss thyroid basics, hyperthyroidism and hypothyroidism, a very high yield topic for your clinical practice as well as for the exams. Now in my class, we learn together. So feel free to repeat after me, understand the concepts and then memorize. Taking notes are encouraged. If you're not able to take notes now, write it down later. So the plan for the session is like this. First we'll start with the thyroid physiology and basics, where we'll cover the radioactive iodine uptake end to end and the thyroid related proteins. Then we'll go to hypothyroidism, where we'll use Hashimoto's thyroiditis as a key topic and discuss all the symptoms, diagnosis, management. Hyperthyroidism after that, where we discuss Graves, decurrence and other causes, symptoms, treatment and management. And finally, we'll have three very specific and important topics: iodine, amiodarone and thyroid resin uptake. Now, thyroid gland consists of the thyroid follicles, right? Numerous thyroid follicles. And this is a follicular cell. This is a follicular cell. And what you have in the middle is the colloid. Okay. Now, this is the canvas we're going to study and learn about the thyroid physiology and a lot of concepts. I'm going to zoom in to a set of follicular cells. This is a zoomed in set of follicular cells. Okay. Now, inside the follicular cells, you have one very important protein which is produced from the endoplasmic reticulum, which is called the thyroglobulin. Thyroglobulin. I like to call it as the mother thyroglobulin because it's the chief precursor protein for the thyroid hormones. Okay. So, and these follicular cells have this end which we call the basolateral membrane and this end which is called the apical membrane. Apical membrane is near the colloid. It's near the colloid. And basolateral membrane is near the blood vessel. Okay. So, thyroid follicular cells like this. You have the thyroglobulin which is produced inside the follicular cells. You have a basolateral membrane which is near the blood vessel, and you have a apical membrane which is near the colloid. Now this thyroglobulin is now then after this will be transported into the colloid. So question, where is thyroglobulin produced? It is produced inside the follicular cell. Where is it stored? It is stored inside the colloid. Question number 2. Thyroglobulin is a marker in specific conditions. Specifically, you might have studied in surgery in well differentiated follicular neoplasm, say papillary carcinoma of thyroid, follicular carcinoma of thyroid. You want to know after treatment if there is any recurrence. You want to know after treatment is there any pending metastasis. What you do is that you measure the thyroglobulin levels. Since thyroglobulin is so much of a protein from the thyroid follicle cells, if there is this follicle cells elsewhere in the body, like in a METS, or if this thyroid follicle cells regenerated elsewhere, it will clearly cause increase in thyroglobulin levels. So the question is, measurement of thyroglobulin levels / increased thyroglobulin levels are suggestive of METS / recurrence in follicular / papillary or well differentiated thyroid neoplasm. Point number 2. Right. So let the thyroglobulin there. Now what we're going to see is iodine. Right. Iodine is the chief raw material for thyroid. Right. See, thyroid is a factory. Which is the primary raw material for thyroid? It's iodine. Iodine, what is the RDF iodine? 150 microgram. 150 mcg is the RDF iodine. It goes up to 220 in pregnancy. This is adult, right? You need 150 microgram. So this iodine is being absorbed from the blood, okay, and it reaches the BL, which is a basolateral membrane, and you have something here. This is a sodium iodine symporter. It is a secondary active transporter. The sodium iodide symporter is actually such an interesting and such a special symporter, transport carrier protein. Why? Because this is the protein, there is a transport protein which makes sure the iodine is being taken into the follicle cells and concentrated there. Think about it, almost 40 times concentration can occur, right? So this guy is what helps this collection of all these iodines and putting it in thyroid cells. But here is another point, MCQ question. It can be found in placenta, It can be found in other places like choroid plexus, mammary gland, breast, ciliary body. Okay. So sodium iodine import, although is very critical, it is not exclusive to thyroid. Okay. Now this importer is the guy who will take up any kind of iodine irrespective of being radioactive or not, and it will help us later down the discussion to treat thyroid diseases, to diagnose thyroid diseases. All this because of the sodium iodine importer. Now the iodine is inside the follicular cell and rapidly taken out into the colloid. And when in this apical membrane, you will find a chloride ion transport, and that transport is called pendrin. Okay, sodium iodine importer and pendrin here. Now, what is the job of pendrin? What is the significance? What is the question you usually get out of pendrin? Is the Penrad syndrome. A mutation of pendrin causes Penrad syndrome, characterized by goiter and sensory neural deafness, because it is found in cochlea as well. Goiter, sensory neural deafness, Penrad syndrome, pendrin protein. Connect the dots. Okay. Okay. So now what we have? We have our two rock stars here, right? We have our thyroglobulin, which is basically a set of tyrosine rings. Like here, and we have our iodine, which is actually iodide, right? Absorbed iodine as iodide. Now this iodine needs to be converted. Iodide needs to be converted to iodine. Super important step. Iodide to iodine. What is the oxidizing enzyme? It is a TPO, thyroid peroxidase, which is the enzyme which the thionamides, right, our methimazole and propyl thyrosol and carbimazoles, they inhibit this particular enzyme, and this enzyme is involved in oxidation of iodide to iodine. Once this iodine is made, this is again attached to the tyrosine rings. So when one iodine is attached, it becomes monoiodotyrosine, MIT. When two iodine is attached, it becomes DIT. Right? Now what happens if you combine MIT and DIT? Again, this enzyme is TPO. This coupling reaction, the enzyme is TPO. What happens if you combine MIT and DIT? You get T3. What happens if you combine DIT and DIT? You get T4. Here are our thyroid hormones. They are ready to be served in the colloid. Now it's going to be taken up back into the follicular cells and then released into the periphery. And in the periphery, you have now the T4 and T3. One specific thing you might know is that T4 will be converted to T3 in the periphery. T4 will be converted to T3 in the periphery. Okay. So T4 is entirely produced from the thyroid. T3 is also produced, but what happens is that a large significant part of T4 is converted to T3. Now this is T4, and we have this enzyme called deiodinases that will convert T4 to T3. There are three types of deiodinases: D1, D2, D3. D2 is the main guy which is involved in T4 to T3. D2 mainly involved in T4 to T3. T4 to T3. Why D1 and D2 is involved in T4 to T3, but D3 deiodinases convert T4 to reverse T3. T4 to reverse T3 is by D3. T4 to reverse T3 is by D3. Got it? Right. So now we have our iodine thing figured out. Now most of the points you might know, right? So what we'll do, we're gonna give radioactive iodine, the cooler version of iodine instead of iodine, right? So it's like radioactive. Okay. So we're going to replace the traditional iodine which body gets from the food and replace it with a radioactive iodine. Now thyroid doesn't mind. Thyroid, any kind of iodine, I'm good, but thyroid will keep taking the iodine up, right? Now at this point, at this juncture, I want you to understand a very important concept. There are two sets of conditions. Okay, and the first set, which I call, is hyperthyroidism, and the quintessential example is Graves' disease. In the first set, you have seen the system here, right? The thyroid, consider thyroid as a factory. Iodine is a raw material. In the first set, which is characterized by, say, example is Graves' disease, there is a real increased production happening in the factory. So there is a real increased need of iodine. Okay, so this happens because the TSH receptor on top of it is being overly stimulated. Assume the thyroid follicle cell is a factory, and there is a real increased production. The factory is working 24 hours overtime. The manager, which is the TSH, is keep saying work, work, work. We have need enough, more. The factory is working, more iodine is taken. So the first set of symptoms or scenario is that there is hyperthyroidism. The factory is overworking. Point number one. The second scenario is that there is a riot in the factory. There is a riot in the factory and there is a release of thyroid hormones to the periphery. All the factory is throwing out the thyroid hormones to the periphery. And what happens? These peripheral thyroid hormones which is being thrown out will suppress the TSH and the factory actually gets shut down. Okay. In this condition, there is genuine stimulation of the thyroid receptor causing an increased production and increased uptake of radioactive iodine or any kind of iodine. The second scenario is basically a situation where the hormones are being thrown out, and these hormones being thrown out will go and suppress the TSH, and there is actually a suppressed state the factory is not producing. Okay, so this is characterized by thyrotoxicosis, right? Two scenarios. Now what happens is that in the first scenario, when you give radioactive iodine, since the radioactive iodine uptake is high, the raw material is needed, and you may put a gamma camera and measure, your thyroid will light up because the real radioactive raw material is there and is being utilized. In the second scenario, if you give radioactive iodine and keep a gamma camera, you will not see anything because there is no uptake of radioactive iodine because the factory is in a right state, the TSH is being suppressed. So that comes to the point, radioactive iodine uptake. It is increased in Graves. A real increase in production of T3 and T4 by increase in uptake of the raw material, which is radioactive iodine. Same scenario in toxic MNG. Same in autoimmune nodule. Same in TSH secreting pituitary adenoma. Alright? Now see this column. Decreased. Subacute thyroiditis. There is a thyroid inflammation. T3 and T4 are thrown out. These T3 and T4 goes and suppresses TSH. And there is nothing happening. The thyroid shuts down. There is a riot in the factory, hormones thrown out, factory shuts down. Viral drug thyroiditis, same scenario. This is there. What is this? Thyrotoxicosis factitia. It is a condition, basically malingering, where a patient is taking external T4 without any disease condition. Patient is taking external T4. What will happen in that condition? There is T4. This T4 will suppress what? The T4 will go and suppress the TSH. So that means there is less thyroid hormone production or synthesis or uptake of radioactive iodine. So this will manifest as decreased radioactive iodine uptake. Thyroid carcinoma with mets, struma ovary. What happens in these two conditions? There is actually thyroid production, just that it's happening elsewhere. Maybe it's happening not in the thyroid, somewhere else. In struma ovary, you have an ovarian mass, ovarian tissue, which produces thyroid hormones, right? So the hormone production happens elsewhere, and these hormones go into circulation, which will suppress TSH. So the factory will be shut down. Again, decrease radioactive iodine uptake. Repeatedly asked multiple times. You need to know this and in and out. And two more points I want to add to this. So think this scenario, what will happen? I'm writing iodine deficiency. Point number one. Point number two. Again, here I am writing recovering thyroiditis. Okay, so this thyroiditis will go into hypothyroidism. Initially there is hyperthyroidism, then go into hypothyroidism, and then it will recover. In these two conditions, you just logically think, right? The thyroid is so much in need of iodine, which is not there, and suddenly you are giving radioactive iodine in an iodine deficient area or in a recovering thyroiditis. The thyroid is hungry to take up iodine. So the radioactive iodine uptake is increased. So if you get a question, iodine deficiency, recovering thyroiditis, RAI is actually increased because of this reason. Now let us see the real radioactive iodine uptake pictures. See, can you see the thyroid here? Practically normal architecture maintained. But what you see here is this. This one place where you don't find the uptake. This is called a cold nodule. Okay. This is cold because in this thyroid, you find that this particular part is not producing the hormones. Why is it cold? Cold is bad because it can up to 10% can be malignant. Harrison says 10%, different books gives different data, but up to 10% can be malignant. So you should really worry about cold. Whereas look at this one. This is a thyroid, and you actually see a functioning part. This is a hot guy. Okay, since the hot guy is active, these other parts are less active. Have you noticed that? Right. The hot nodule is not much of a problem. Okay, when a malignancy perspective. Okay, so this is a cold nodule, this is a hot nodule. What is this? It's a lit up thyroid. Wow. Graves, the factory is functioning. More radioactive, everyone is busy. The lit up thyroid. Grave. What is this? You have a thyroid which you can't even see. It is basically an autonomous nodule. So it's more like a granddaddy of this hot nodule, right? It is so autonomous that it's making the other part of thyroid irrelevant. It's not needed. And what you see here is a multinodular goiter. See, active, this is like active areas, cold areas. It's like multinodular goiter. And finally, what you see here is the RII picture of thyroiditis / thyroid toxicosis factitia / thyroid mets / truma ovary. All this scenario, the thyroid hormone is there in the circulation, which will go and inhibit TSH, which will shut down the factory. And what you end up is that the thyroid is nothing is happening in the thyroid. You can't even make out the thyroid in a radioactive iodine uptake study. Alright, cool. Now, let us look at the thyroid proteins. TRH, TSH, you know about the hypothalamo-pituitary axis, right? Hypothalamus secretes TRH, which goes and tells TSH, increases the TSH, which goes and stimulates the TSH receptor in the thyroid. You get increased T3 and T4. Then the feedback mechanism, negative feedback kicks in. The T3 and T4 can go and inhibit the TSH as well as the TRH. Simple, straightforward. Thyroglobulin we discussed, the mother globulin synthesized from the follicular cell. It is used in very particular scenario. It's basically to evaluate or to find out if there is thyroid carcinoma mets, or which especially the follicular neoplasm and the papillary, if there is a mets or there is a recurrence. This is one I want to discuss thoroughly. TBG, transthyretin albumin. See, these are all physiology topics, but medicine is basically physiology gone wrong, right? So these all have clinical relevance. All these points will be repeatedly will come into picture in hypothyroidism as well as hyperthyroidism. Then we are going to discuss T3 and T4. Let us look at the thyroid binding proteins. It is usually for the transport. First is albumin. Only one thing you need to know. Capacity. I'll write big. Okay, capacity. Albumin has the largest capacity. Albumin has the largest capacity, while thyroxine binding globulin, the second guy, has the maximum affinity. Okay, the maximum affinity. And if you look at most T3 and most T4 are bound to TBGs. Okay, so practical purpose, your binding protein is what? TBG. So that brings us a challenge. Any condition which increases TBG or any condition which decreases TBG will change the bound quantity of protein. See, thyroid hormones can be bound and unbound. As always, unbound protein is the most active protein. Okay, most active hormone. You want the unbound. But bound acts as kind of a reservoir, right? So this TBG will be the friend of the bound hormone, right? The bound hormone itself means it's bound with the maximum TBG. Now there are scenarios, not this down. There are scenarios like repeated ask. TBG excess. There are scenarios where there is decreased TBG. TBG excess occurs in pregnancy. TBG excess occurs in pregnancy and estrogenic states, for example, estrogen containing OCPs. Okay, when there is high estrogen or when there is pregnancy, TBG excess happens. TBG deficiency happens in protein losing states, example, nephrotic syndrome, androgens, liver disease, acute intermittent porphyria. TBG deficiency happens in protein losing states, example, nephrotic syndrome, androgen excess or androgen given as a drug, liver disease. These conditions, acute intermittent porphyria, these conditions, there is a TBG deficiency. So in these conditions, if there is a TBG excess, there is more TBG to bind. So if you measure a total hormone, it will be high. In TBG excess, if you measure the total hormone, it will be high. If you measure the unbound, it will be high. If you measure the free T4, it will be normal. Okay. Now the third one is transthyretin. What is peculiar here? Thyroid, retinol. Thyretin. So it is also involved in the retinol transport. You see retin here? It's also involved in the retinol transport. And you might remember this percent from our first table in QBank. If you go to the amyloid questions here, you will find this is the protein which is being misfolded in systemic senile amyloidosis, familial amyloidotic neuropathy, lateral point. So you need to connect your subjects and study, which is so critical so that you actually remember and recollect better. So the lateral point is that transthyretin is the protein which is being misfolded in familial amyloidotic neuropathies and systemic senile amyloidosis. That's the connection to transthyretin and amyloidosis. Okay. Albumin capacity, globulin affinity, transthyretin, retinol, and as connection here. Now let's come to T3 and T4. All of you know what is it, right? Right? This is quite straightforward. T3, if you don't know, T3 is the rapid, I am ready, I will do the fast guy. T4 is like more mature, more controlled, more half-life, more bound. Okay. T4, the bound fraction, the fraction of unbound is actually 0.2. T3. T4 is actually 0.02. It is unbound. Okay. So unbound is more in T3 because so that it can immediately act, right? Unbound fractions are active. Unbound are the active fractions, right? It is immediately active. So T3 is like more unbound. Okay. T4 is less unbound, or more T4 is bound to the TBG and other proteins. Okay. Unbound percentage is 1. This is important. Okay. This is the specific you need to know. Okay. What is the half-life? This is 1 day. Rapid guy. T3 is our rapid guy. Our stable guys of half-life is 7 days. Okay. Half-life, right? You need to know this. Okay. Then others you can actually, this is T4 is converted to T3. This is rapid acting. All these points I think you knew otherwise. What else you need to know? Yeah. One more thing. Relative metabolic. This is 4x. This is x. 4 times more potent. T3 is 4 times more potent. Okay. Decreased radioactive iodine uptake is seen in. We have discussed this in and out. The answer is factitious thyrotoxicosis. Now, in factitious thyrotoxicosis, one more investigation is relevant. It is thyroglobulin. It is decreased. Okay. Why? Because there is no need. There is an external supply of thyroid hormones. The thyroid follicular cells need not even produce thyroglobulin. Okay. So it will be decreased. So these thyroglobulin levels are normal or high in other causes of thyroiditis. Okay. So the thyroiditis, so radioactive iodine, if it is depressed, you suspect mainly 3 things, of which one is thyroiditis, second is a carcinoma mates or struma ovary, and the third one is factitious thyroiditis. Only in factitious thyroiditis you have decreased thyroglobulin. That percentage of T3 is produced in periphery. 84% of T3 is produced in periphery. Which of the following statement is false? Okay, now look at this statement, right? Unbound iodine is excreted in urine. Yes, unbound iodine is excreted in urine. In fact, do you know about iodine deficiency? How do you say that, the place where you live is iodine deficient or not? Is that if you have to measure your urinary iodine. If your urinary iodine is greater than 100, it means it's iodine sufficient. If your urinary iodine is less than 50, it is iodine insufficient. There is iodine deficiency. Okay. Unbound iodine is excreted in the urine and it is measured to say if there is urinary sufficiency or deficiency. 10 to 20% of the radioactive iodine is taken up by normal thyroid in 24 hours. Note it down. It's an exact verbatim copy from Harrison. Okay, 10 to 20% of radioactive iodine is taken up in a normal thyroid in the 24 hours. Okay, so it can go up. If there is grave, it can even go to 60%. Pindrin is an iodine transporter, correct, located in the basolateral. This is wrong. We've seen it thoroughly. It is located in the apical membrane. It is located in the apical membrane. Majority of the T3 and T4 are protein bound. So you know the answer. Alright, now next question. Which of the following statement is false? T4 is converted to T3 in the periphery. T3 is metabolically active than T4. Thyroglobulin is synthesized in the thyroid cells, of course. Majority of T3 and T4 are synthesized in the thyroid follicular cells. No. Majority of T3 happens, 84% of T3 occurs in the periphery. And if you want to dissect it further, you can even debate this. It's not in the follicular cells, right? It's in the follicle or in the colloid. Okay. So anyway, majority of T3 is not produced or synthesized inside the thyroid. It's actually periphery. So that forms the answer. Which of the following is false regarding circulating thyroid hormone? Most circulating T4 is bound to thyroid binding globulin. Yes. Most circulating T3 is bound to albumin. No. No. T3 is also bound to TBGLU. Okay. Free T3 and T4 are physiologically active. TBG has higher affinity for binding T3 and T4 than albumin, of course. Okay. So B is the answer. Now let's look at the thyroid function test. TSH is the most sensitive in the thyroid axis. Okay. Fourth generation TSH assays can measure up to 0.004 milli-international units. Now this is helpful in differentiating the cause of hypothyroidism, right? Okay, so TSH assays, this is directly from Harrison. It was asked for the NEET exam. Fourth generation TSH assays can measure up to 0.004 milli-international units. Free T3 and T4 measure the physiologically active T3 and T4 in circulation. Total T3 and T4 measures the total is basically measures the free plus bound. Okay, straightforward. One confusion is this set, right? Anti-thyroid antibodies. Actually, it's not your fault because there are different and confusing nomenclature, right? So we'll clarify all of this. We're going to see thyroid autoantibodies here. Do you remember? Of course, you remember our follicular cell. There are three main stars or three main targets for our autoantibodies. The three poor guys which are often attacked or targeted. The first person is our TSH receptor. Okay, first person is the TSH receptor. Do you know who is the second person? Of course, you know it is the TPO. It is the TPO, thyroid peroxidase inhibitor. Now the third guy. Third guy is no one other than the TG, thyroglobulin. Okay, thyroglobulin. This antibodies, it is the TSH receptor antibody. Okay, the TSH receptor antibody. We also like to call it TRAB or thyrotropin receptor antibody. You need to kind of get this into your head. These are the TRAB antibodies. In the TRAB antibodies can be stimulatory or inhibitory. So for example, let's say in the receptor there is a stimulatory antibody. It will keep stimulating the TSH receptor and the TSH receptor will go and keep activating the thyroid, resulting in Graves' disease. So in the TRAB, what do we measure? The TSI, thyroid stimulating immunoglobulin, or TBII. Okay, thyroid binding inhibitory immunoglobulin. Okay. And these are found in Graves. Okay, got it? There are three rock stars or three unfortunate victims here. One is the thyroid receptor, often attacked, TPO, often attacked, thyroglobulin, often attacked. If it is a thyroid receptor antibody, you have the TSH receptor antibody. We like to call it the TRAPs. And the TRAPs we do the TSI and the TBII assay, and this is typically found in Graves' disease. Okay, Graves, TRAB, TSI, TBII are the keywords. Graves, TSH receptor antibody, TRAB, TSI, TBII. Okay, any of this can be asked. Now let's come to the next guy. It is a TPO, anti-TPO antibodies. Anti-TPO antibodies are found in Hashimoto. Okay, anti-TPO antibodies are found in Hashimoto. Simple. Thyroglobulin. Anti-thyroglobulin antibodies are found in again Hashimoto. So we have anti-TG and anti-TPO. both in Hashimoto. Which is a better one, which is more sensitive? Anti-TPO. Okay, so if you suspect Hashimoto and if you have to check if there is Hashimoto, no need to do the TG, anti-TG antibody, only do anti-TPO. Okay, only this is needed, this is good enough, right? So that's also clear. So in Hashimoto, it is anti-TPO. In anti-TG, also high in Hashimoto. Okay, but usually not needed nowadays. This is also called for strange microsomal antigen. Okay, this is a microsomal antigen, old name. So if for strange reason, if you get the word microsomal, don't be confused. It is associated with the anti-TG. Now, I am not saying these antibodies are all exclusive. For example, anti-TPO can be positive. I mean, a lot of, I think 70 up to 60% of graves can have anti-TPO antibody. Anti-TG can be in grave. TSR receptor antibody can be in many found conditions, including Hashimoto, right? There are this cross presence of these antibodies which you need not worry about. What you need to worry about it, which is specific to what? TSH, TRAB, TSI, TBII, grave, anti-TPO Hashimoto, anti-TG Hashimoto, but Hashimoto we only need TPO. Which of the following statement is false? It's an amalgam of 3 to 4 MCQs. We'll go one by one. RA, radioactive iodine uptake is low in factitious thyrotoxicosis. Yes. Thyroglobulin levels are low in factitious thyroiditis. Yes. D1 deiodinase oxidases iodine to iodine. No. We said what oxidase to iodine, which is the attacking target of anthionamides, which is basically the TPO, right? It is not deiodinase, it is the TPO. Thyroid hormone synthesis starts at 6 weeks of gestation. Factual question given in Harrison as well, it is 11 weeks, okay? It's not 6 weeks, it's 11 weeks. Iodine devoid diet for 2 months will not produce hypothyroidism. See, thyroid hormones is such a fundamental hormone for human growth and survival, right? So body has this mechanism of a storage where you don't have zero iodine for 2 months, you won't get hypothyroidism. Okay. Albumin has the largest affinity. No. Albumin has the largest capacity. Okay. NIS is exclusive to thyroid. No. It is also found in salivary, breast, choroid plexus, placenta. Okay. So the answers we are corrected, right? This is correct. Got it? All are repeat questions. Any doubt, go back and read again. Peripheral conversion of T4 to T3 is reduced in major burns, yes. Selenium deficiency, yes. Amiodarone use, yes. Amiodarone is basically iodine because it has large portion of iodine. Answer is all of the above. Did we discuss selenium? Do you remember our deiodinase, the enzyme which helps T4 to T3 conversion? This is D1, D2, D3. Selenium via selenocysteine is an important part of this enzyme. Okay, selenium has a connection to D1 deiodinase. Okay, Keshan disease. PSM Park, right? Keshan disease. Congenital cardiomyopathy with the selenium deficiency. Unrelated, since we discussed about selenium, I'm just writing it. Keshan's disease, congenital cardiomyopathy with selenium deficiency. Let's come back to the point. D1 deiodinases, right? These deiodinases need selenium as a as a trace mineral. Okay, selenium deficiency can cause this. So peripheral conversion from T3 to T4, so important. Iodine, propranolol, steroid, contrast, which again contains iodine, PTU, major stress or sick euthyroid scenarios. Let me read once more. You are not going to write the exam without knowing this. Peripheral conversion is inhibited by iodine, propranolol, steroid, contrast, PTU, major stress or any condition which will result in a sick euthyroid syndrome. Okay. Now here we are. Iodine effects on thyroid. These are two syndromes you might have studied and you might know, but you need to know a little deeper for your exam. Your exam, you will get conceptual questions, you will get a deeper questions, you are not going to get very straightforward questions. Obviously, straightforward questions everyone will answer. Where you score is basically when you answer deeper and study deeper. Two syndromes I want to mention. Wolff, Chaikov, you know that, right? Jod based O. Usually just you study as a footnote. No, it's very important. Wolff-Chaikoff is a protective mechanism in the human body where iodine has this habit, because thanks to the sodium iodine importer, iodine has this habit of taking up iodine like whatever it comes, right? What happens if there is so much of iodine? Then the body itself has a protective mechanism where excess iodine inhibits a step in the process of thyroid hormone synthesis, so causes hypothyroidism. Excess iodine paradoxically inhibits this production of thyroid hormone synthesis, and that part is organification. Okay. Organification is that part where iodide is converted to iodine and then coupling. That organification is actually inhibited. So Wolff-Chaikoff effect, iodine inhibiting iodine or thyroid hormone synthesis and resulting in hypothyroidism. Protective mechanism. Wolff-Chaikoff, by inhibiting organification, excess iodine will cause hypothyroidism. Point number 1. We will use this mechanism in treating hyperthyroidism. Okay. For example, if there is a thyroid storm, you will give potassium iodide. Before a thyroid surgery, you will give potassium iodide. Okay. We will all use this. If in a neonatal thyrotoxicosis, we will use this mechanism to treat. So basically, you give thyroid iodine to treat hyperthyroidism and resulting in hypothyroidism. Wolff-Chaikoff. What is Jod-Basedow? Now, Jod-Basedow is iodine causing hyperthyroidism. Iodine causing hyperthyroidism. Iodine causing hyperthyroidism is Jod-Basedow. Now this Jod-Basedow will come back by the end of this session after 1.5 hours or so in amiodarone induced thyrotoxicosis. It's actually very interesting. How can you are saying iodine causes hypothyroidism. Now let us see how iodine will cause hyperthyroidism. Okay. There are two mechanisms, mechanism 1 and mechanism 2. There are other mechanisms, but this is what we need to know. JBDM1, JBDM2, mechanism 1 is this. You are giving iodine to a patient or a user or an individual who actually have a background hyperthyroid disorder. For example, this patient actually has Graves. But the funny thing is that the patient does not have increased T3 or T4. Even though the patient has Graves' disease, the patient does not have increased T3 or T4. You know why? The patient is living in an iodine deficient area. See, this patient, I am the patient, right? And my thyroid want to produce lot of hormones T3 and T4. The raw material iodine is not there because the soil is deficient, the food is deficient, right? So in this patient, you are suddenly giving iodine. The thyroid is so hungry to see some iodine. What will happen? It will take up all the iodine because of the underlying Graves' disease, because of the underlying iodine deficiency. It will produce hyperthyroidism. It will produce excess hormones, right? So in the first mechanism, there is an underlying thyroid disease, like hyperthyroid disease, like example is Graves, and it occurs in an iodine deficient area. I usually kind of think one more condition with this. It's basically polycythemia. I don't know if you have seen a patient. There is a thrombocyte. So if you in a typical polycythemia patient, you accept the hemoglobin to be very high, right? What if the patient is living in an iron deficient state? Will the hemoglobin be very high? No. The patient only will have thrombocytosis. Okay, English platelet will be there, and the hemoglobin will be normal or high normal. The moment you give iron to the patient, the moment you give the iron deficient polycythemia patient, you will see that hemoglobin going up like that. Similarly, this patient with an underlying thyroid disease, living in a iodine deficient area, you give iodine, there is hyperthyroidism, mechanism number 1. The mechanism number 2 is simple. It's basically a thyroiditis mechanism. Like it's an inflammatory mechanism where this iodine creates a thyroid inflammation, releases the hormone, causing the thyroiditis. I'm discussing this in detail because Jod-Basedow we will utilize in amiodarone induced thyrotoxicosis later. Regarding iodine, which is false? It inhibits synthesis of thyroxine. Yes, it is. Contraindicated in hyperthyroidism? No, I just said we are going to use this Wolff-Chaikoff effect in few conditions like hyperthyroidism before surgery, thyroid storm, hyperthyroidism in an acute state, or neonatal hyperthyroidism. We're going to use iodine, right? It's not contraindicated. In fact, it's used. Prevents peripheral conversion of T4. Yes. Can cause hyperthyroidism. Yes. Okay. So the answer which is fault is that it is not contraindicated in hyperthyroidism. In fact, it is used. Now, let us come to hypothyroidism. Okay. Now, hypothyroidism, if you think about it, right, or let's think about thyroid hormone. Thyroid hormone is such an important hormone starting from the early days of the fetal life to the adult life. Okay. It is important for the normal maintaining the normal metabolic function. It is a calorigenic hormone. Thyroid hormone is a calorigenic hormone which helps utilizing the oxygen. It is a hormone which makes sure there is, blood sugar available, glucose available. It is needed for the contractility and functioning of the heart. It is needed for adequate reproductive function. You will see what happens if there is hypothyroidism, right? All these symptoms. And it is needed most importantly for the normal development and maturation of the central nervous system. Okay, so hypothyroidism obviously is a deficiency of these thyroid hormones. Before getting into the causes of hypothyroidism, first let us stop here to just discuss about congenital hypothyroidism. Now, congenital hypothyroidism, what is the most common cause? Do you know? If you get a question, your answer is thyroid dysgenesis. Okay? If you get a question, what is the most common presenting symptom of congenital hypothyroidism? Then your answer is this. Symptomatic. Okay? Most babies won't have any signs or symptoms. That is why we always look and screen for congenital hypothyroidism, right? Immediate newborns, we screen for congenital hypothyroidism because it is such a preventable cause of mental retardation. Comes to the third MCQ. Most common preventable cause of mental retardation. Most common preventable cause of MR. So you actually make sure you screen all the individual babies for congenital hypothyroidism. Now, if the baby ends up having congenital hypothyroidism, what do you notice? Fontanelle will close late. Okay, fontanelle will close late or delayed closure. You will see macroglossia. Okay, you will see umbilicus protruding or hernia. You will find hypotonia. You will find lethargy. You will find a kind of a hoarseness. You will find delayed jaundice. Okay, delayed jaundice, that's important. Okay, so most babies are asymptomatic. If you find these will be the features of congenital hypothyroidism. Did I mix anything? Yeah, bit of puffy myxedemas, a hoarse cry will be there. There will be feeding problems, umbilical hernia, hypotonia. Okay, now let's come to the adult causes of hypothyroidism. I'm going to divide it into 3M. Okay, so first is primary. There is a gland problem. In the primary, most common is autoimmune, and you know the name, right? Nothing? What is the name? Yes, Hashimoto. Hashimoto autoimmune. What is the second cause in primary? Drugs. We'll see which are the drugs. Next one is iatrogenic. Very common actually, right? You take out the thyroid, our surgeons are taking a thyroid like dish, right? Thyroid is taken out, you give radioactive iodine, any of this, iatrogenic. Okay. One more thing, infiltrative. This also we'll see. Okay. So we know autoimmune Hashimoto, iatrogenic we know, drugs and infiltrative we'll see. Very important actually this. Repeatedly ask questions. Especially NEET exam, Central Institute not much, but NEET exam, primary hypothyroidism causes, symptoms, sign, you can't live without it, right? We'll see this in detail. So these are the primary causes of hypothyroidism. Now what is the second thing? You have the central cause. So central cause is very easy. The hypothyroidism is because of the TRH deficiency or the TSH deficiency. For example, there is a hypothalamic cause, causes TRH deficiency. There is a TSH deficiency, like say Sheehan syndrome, a pituitary adenoma, right? There is a TSH deficiency. Mostly there are other symptoms as well, other associated hormone deficiency symptoms as well. So that's a central cause. Primary, central. Central can be TSH or TRH deficiency. What is the other one? The middle one we actually call transient. So these are a group of thyroiditis. So I'll give you a simple fund about thyroiditis. Understand this. Thyroiditis, the thyroid hormones, thyroid is getting inflamed. The thyroid hormones are thrown out. There is a riot in the factory. There is no increased production in the factory. When you throw out the hormone, initially there will be hyperthyroidism, followed by a hypothyroidism, followed by a recovery. So this transient guy will find place in hyperthyroidism as well as hypothyroidism. Okay. This is the table from Harrison. Okay. Spend some time here. So primary, transient, secondary. So secondary C, tumor, pituitary surgery, irradiation, infiltration, everything. What you need to specifically discover and discuss is these two. In primary drugs, in primary infiltrated disorder. I told you, no, I'll discuss later. Repeated questions. In drugs, what are the drugs that causes hypothyroidism? Iodine excess by Bulchakov. Also iodine containing contrast media. Amiodarone, which is practically a lot of iodine. Lithium. Antithyroid drugs, obviously. Aminosalicylic acid. Interferon alpha and cytokines. Aminoglutathamide. Tyrosine kinase inhibitors. Drugs causing hypothyroidism. Okay. Infiltrative diseases causing hypothyroidism. This is a bit tricky because you don't suddenly realize, okay, these conditions can cause. But often in an MCQ, these are often repeated as options. Amyloidosis can cause hypothyroidism. Sarcoidosis can cause hypothyroidism. Hemochromatosis can cause hypothyroidism. Scleroderma can cause hypothyroidism. Cystinosis can cause hypothyroidism. Our woody renal thyroiditis can cause hypothyroidism. Note the points down. Drugs, one list. Infiltrative, one list by heart. Okay. Now we identified the cause of hypothyroidism, right? We found what causes hypothyroidism. Now we're gonna take one very specific individual hypothyroid condition, which is Hashimoto. I'm gonna see it in detail. This is the index case. Now, Hashimoto's thyroiditis, it is autoimmune. Point number one. Whenever you see autoimmune, always think the other autoimmune disease can come as association. Most common cause of hypothyroidism. There are two phases. One is early goitrous and late atrophic. In this, what I want you to really focus is it's firm, non-tender. There's no pain. Okay. Firm, not tender. Early goitrous, late atrophic. A short period of hashitoxicosis in the early stage, because anyway it's a thyrotoxicosis, right? Thyroiditis, right? So basically in that initial phase of thyroid being thrown out, there is a short phase of hyperthyroidism. It is called hashitoxicosis, and there is marked lymphocytic infiltration. In fact, an army of lymphocytes will come like a war and gonna attack the thyroid and basically replace the entire thyroid tissue with this lymphocytic infiltration and basically rendering the thyroid useless. Okay, it just damages the thyroid. Okay, this is an army of lymphocytic infiltration, and from a pathology perspective, you find Hurthill cells. Okay, you find Hurthill cells. Okay, it's also called Ashkenazi cells. Okay, there's a Hurthill cell tumor, so this is often confused with the Hurthill cell tumor, right? Now, this has an autoimmune association. You look for pernicious anemia, you look for adrenal insufficiency, you can look for type 1 DM, you can look for celiac disease, maybe it is associated, right? So these are the other autoimmune diseases which I mentioned can be associated, right? Downs and Turner can have hypothyroidism as association, and if it is associated, the most common cause of hypothyroidism in Downs and Turner is actually Hashimoto. Okay, Downs and Turner can hypothyroidism, and if it is associated, it is Hashimoto. And there is one more thing, Hashimoto's encephalopathy. This was asked previously. So how do we understand Hashimoto's encephalopathy? It is I will give you the keywords. It is a steroid responsive encephalopathy with the slow waves in EEG and anti-TPO antibodies are positive. Okay. Steroid responsive basically you have to rule out all other causes of encephalopathy. Then you find TPO antibodies are positive, maybe or may not be associated with hypothyroidism. It is steroid responsive and there is slow waves in EEG. Then that is most possibly Hashimoto's encephalopathy. Note down the keywords. Okay, now we come to one of the most significant part, clinical features of hypothyroidism. Now here's the tricky part. A hypothyroid patient coming to you in the OPD, you can get an idea, right? Bit obese, a slow, tired individual with some aches and pains, weight gain. We know all the superficial symptoms, but we need to go into the specifics because you get questions in the specifics. I'll give you start with the example. Do you think is there a thin skin or easily bruisable skin in hypothyroidism? Actually no, right? The skin in hypothyroidism typically is called myxedema. There is a coarse, thick, dry skin with underlying glucosaminoglycan deposition and it's a non-pitting kind of edema. Non-pitting edema, glycosaminoglycan GIG deposition, dry skin because there is decreased squitting, which is basically called myxedema. Okay, so you need to clearly know it is not a thin skin. Point number 1. Carotenemia. Thinning of hair and outer third of eyebrows. Hoarseness of voice. Carpal tunnel syndrome. Association with hypothyroidism. Memory and concentration impairment. This often seems confusing. See, there is a mentation problem, right? It affects CNS. You can actually get memory and concentration impairment. Myopathy. Slow relaxation of tendon reflexes. Okay. Slow relaxation of tendon reflex. Asked a question which is called pseudomyotonia. Slow relaxation. It's not a slow reflex. It is a slow relaxation. Reversible cerebellar ataxia. These are the neurological manifestations and very interestingly conductive deafness and in some cases actually sensory neural deafness as well. So can hypothyroidism affect your ear? Yes. It can cause serous effusions like pleural effusion, pericardial effusion, all the things, right? Or maybe some effusion can occur in the ear cavity also, maybe in the middle ear. So it can definitely cause conductive deafness. It can cause sensory neural deafness, by example Pented syndrome. Okay, so hypothyroidism can cause hearing problem. Asked, repeat question. Okay, now we have one more slide. Okay, if you thought that was over, we have one more slide. Continuing the clinical features of hypothyroidism. See, menorrhagia first and oligoamenorrhea. So you can have menorrhagia as well as amenorrhea in hypothyroidism. But typically, the first to occur is menorrhagia. So usually everything slows down except your periods. That's how you say it, right? Everything slows down except your periods. It's actually not a fun thing for a female patient, right? Everything slows down except your periods. Also, I would usually add everything slows down except your periods and pressure. Look at the last point. Oh no, the second last point. Diastolic hypertension. Okay. Everything slows down except the periods and pressure. Okay, but the periods can slow down. No, it can be hyper. Then actually go into oligo and amenorrhea later. So chronic disease or maybe iron deficiency. All this causes. Reduced fertility. Galactorrhea. Yeah, this you need to know. Galactorrhea. What is the mechanism? What is the mechanism for galactorrhea? Can anyone say what is the mechanism for galactorrhea? Physiology. You have hypothyroidism. That means two other hormones in the HPA axis is overacting, right? TRH is very aggressive acting, TSH is also high. TRH actually has action on two things, right? One is in the TSH. See, TSH stimulates TSH as well as prolactin. Open your Ganam and see, right? TRH stimulates prolactin, maybe this itself is an MCQ, and TSH. Since it stimulates prolactin, what happens? You will get galactorrhea. And when we see the clinical features hypothyroid, you will see that there we see gynecomastia. So here we get galactorrhea. There in hyperthyroidism, later down in this discussion, we'll get gynecomastia. Weight gain despite poor appetite. Okay, patient is not eating much, but the patient is gaining weight. Hyponatremia, mostly dilutional hyponatremia, is the characteristic metabolic or abnormality. Hyperlipidemia. See, thyroid hormone helps the clearance of the cholesterol metabolites and the products. So, when there is low thyroid hormone, hyperlipidemia is the end result, as well as hyperhomocystinemia. Anemia. Typically normocytic, normochromic can be there. Can it be macrocytic with megaloblasts? Marrow, yeah. Do you know why we call marrow, our platform? Marrow is pluripotent, right? It forms the base of everything. So, we want to have marrow as base learning platform where you understand and learn your concepts. Okay, that's why I call this platform marrow. Come back to anemia, marrow megaloblast. Where can it occur? Why can it occur? Why should it occur? It occurs because of one reason which I said, that this is an autoimmune. Other autoimmune condition can be associated, and one other autoimmune condition which I mentioned was pernicious anemia. Pernicious anemia. So if there is pernicious anemia, what will you see? Megaloblasts, macrocytes with megaloblasts. And the third, you can actually have microcytic anemia. Why? Look at the first point in this slide. What is the first point in this slide? Yes, menorrhagia. Iron deficiency anemia, blood loss. Okay. Diastolic hypertension. So there is increased peripheral resistance. So basically diastolic hypertension, and finally followed by bradycardia. Let me put a tick there. Okay. Alright. Now we come to diagnosis and why and how we use TFT in hypothyroidism. I'll make it very straight, simple. You measure TSH. Okay, you measure TSH, you measure T4. What do you expect? What do you expect, right? It's a traditional primary hypothyroidism, right? You find that this is low, this is elevated, right? Okay, so most cases that's good enough. Patient hypothyroid, TSH high, T4 low. Most cases good enough. Primary hypothyroidism suspected. And most cases are due to what? Hashimoto's thyroiditis. So you need not even actually technically confirm it, but go ahead and confirm it. How will you confirm? You do anti-TPO. You do anti-TPO. If anti-TPO is positive, you say it's Hashi. If anti-TPO is negative, you look for iodine deficiency, drugs, radiation, therapy, all the other causes. Okay. Now, that's when we get a TSH high, T4 low. What if you get TSH high, T4 normal? Actually, this is not rare. Okay, this is number 1. This is number 2. This is not rare. You can actually get this. So this is called subclinical hypothyroidism. Okay. Why? Because the TSH is actually very sensitive. See, T4 will barely manage, right? Oh, the thyroid will work hard more. But TSH is not like that, right? TSH is like very sensitive. So it will just move like this. Right? The needle will move very much, right? So this is actually an indication that there is actually subclinical hypothyroidism. Okay. Now here what is suggested is that usually it's recommended to measure TPO. Okay. What if the TPO is positive? You can actually say it's a Hashimoto, but it is not manifested with a low T4/8. Okay. Now usually if so what to do in these conditions, right? In most cases you can actually treat. Okay, because the treatment is quite safe and simple. Most cases you can treat, and specifically if the value, if it is greater than 10, the TSH is greater than 10, or if there is a symptom, say infertility or menorrhagia, if there is any of these symptoms or if the TSH is actually much elevated, you can actually treat subclinical hypothyroidism. Alright? Cool. Now third, what is the third permutation or combination? TSH, T4, the T4 is low. You expect TSH to be high, but it is not high. It is normal. Okay. Or it's a mildly high. What did I tell you right now? TSH is very sensitive, right? If there is a low T4, TSH will be like high. If it is mildly high or normal or even mildly elevated, that is a cause for suspicion. It's acting weird. So something else is going on in the HPA axis. This is a signal, or this is an indication for what? This is an indication for central hypothyroidism. Right? This is an indication for a central hypothyroidism. Now let us see a central hypothyroidism. What do you do? central hypothyroidism. Others are clear, right? Primary is clear, right? So central hypothyroidism could be due to oh my god, this looks like a testis, but it's actually, I was trying to draw it pituitary. In fact, once in my class someone said it's a testis, and I asked why. He said because sir, you're drawn left testis in a lower level. Okay, so maybe I'll not draw it here. I will write pituitary. Okay, central pituitary. Other source is hypothalamic. Okay, these are the two sources. What you do is a TRH stimulation. Okay, you don't need to understand anything. You give, you sort of suspect central hypo. Now you want to know which is which. Okay, and to be honest, this is not a very practical way we do right now, but you know, for your current conceptual understanding in exam, we think you give external TRH. Now you give external TRH. What is the problem if it is a pituitary cause? The TSH is not there. Example, Sheehan syndrome. There is no production of TSH. So even if you give external TRH, something is going to change here. If you measure TSH, what will happen? It will just remain same. Okay, it will just remain same because the TSH is not there. Whereas in hypothalamic, wow, finally some TRH, the TSH will be so happy to be raised, and it is a delayed raise. Okay, since it is an external TRH we are giving, the TSH will be elevated. So there is a delayed rise in TSH in case of hypothalamic. There is no change in case of pituitary. Treatment of hypothyroidism. Okay, treatment of hypothyroidism. It's quite straightforward. So you give T4. You don't give T3. Why? See, T3 is actually better absorbed. Okay, and but we give T4. One, it's actually not short acting, right? You don't have to give multiple doses, right? The duration is happy. You are happy with the duration of action. Second is, even if you give T4, it will get converted to T3 in the periphery. Okay, so and it's much easier to measure. Okay, so we give T4. What is the T3's name? Liothyronine. Okay, liothyronine is the T3. Okay, we don't give it. We give levothyroxine. 1.6 microgram per kg per body weight is the dose. Okay, is the adult dose. Dose adjustments based on TSH. So you start with the dose, then you actually titrate up or titrate down. For that we use TSH. But let's say you have a patient, Hashimoto's disease, you give started on levothyroxine, it is available as 50, 25, 50, 100 mcgs. Started on say 100. When do you measure the TSH? You wait for 2 months, okay? Don't measure immediately. Don't measure the next day, next week, next month. You can actually wait for a few weeks to measure the TSH. Now, certain patients will have a good relief. When those patients who has good relief, ask them not to stop the medicine. If they don't have a good relief, you have to wait up to 6 months. Okay, these are clinically relevant points. What are the other points? You're giving levothyroxine. Patient has to take in the early morning, ideally 30 minutes before the food, because you don't want something in the food, say goitrogen or anything, to inhibit this. Okay, 30 minutes before food. Do not give it iron, calcium, amiodarone. Do not give it levastatin. Do not give it iron. PPIs. All these drugs will inhibit the absorption. Actually, where is it pretty important? It's pretty important in pregnancy because you anyway give iron and calcium, right? So you make sure if there is a hypothyroid patient, you're on treatment getting pregnant, she's not mixing or taking these medicines with her iron and calcium. Now, I think we covered most of it. Yeah, one more thing. What happens if someone misses a dose? You can actually give one more dose. The half-life is 7 days, right? So today a patient misses a dose, you can actually give. If there is no response, suspect non-compliance, suspect other medicines, suspect absorption issues, malabsorption syndrome. Okay, but if you see this thing, okay, you have a patient, still T4 is normalizing, T4 has no problem, TSH is remaining high. You will find all sort of patterns, but some patients both will be disturbed. But if they see this pattern is that T4 is normal and TSH is still high. One thing you need to kind of think about is that one tricky thing here is that the patient might be taking, let's say I have appointment next Friday I have Friday appointment. Okay, great. Patient will start taking T3 and T4 from Tuesday, Wednesday, Thursday, Friday, because I'm going to the doctor. He will order the test, right? So the patient is taking T4 just few days prior to the repeat visit. The T4 will get normalized, but the TSH, it is so sensitive, right? It will not get normalized. So if you see such a pattern, still suspect non-compliance, and probably the patient is taking the medications near to the review or the visit or the test date. Okay, now come to iodine deficiency. As I said, right, 150 microgram is the RD of iodine. Pregnant patients 220 to 250 you have to keep pregnant and lactating. Urine iodine of excess of 100 mcg means iodine sufficiency. Less than 50 means iodine deficiency. In that area. Okay. Can cause diffuse and nodular goiter. If there is a lack of iodine, what will happen? The thyroid hormone, there is increased TSH because there is low reduced T3 and T4. There is an overstimulation by TSH. The thyroid gland enlarges. And then what happens? Right? You end up in a simple goiter. Okay. And if the thyroid gland enlarges and there is an architectural distortion, you end up in a multinodular goiter. And if the multinodular goiter loses it and starts producing thyroid hormone by itself, you end up in a toxic MNG. Prevalence rate of iodine deficiency disorders in India as of 2016 is actually 3.8. That's what our park says. Double fortified salt is actually, we all know salt is fortified with iodine. If it's fortified with iron as well, that forms a double fortified salt. Which of the following is not a goitrogen? Cauliflower is a goitrogen. Cabbage is a goitrogen. Turnip is a goitrogen because these all belong to a family of vegetables called Brassicaceae family. Okay. Lettuce does not belong there. You can realize, right? Now, this has, why it's a problem here? This has isothiocyanates. Sort of acts like the thionamide. Okay. So these three can cause hypothyroidism, and it is a goitrogen. Some other peanut, soya milk, radish also can actually cause some kind of cassava. Answer is lettuce here. Most common symptom of hypothyroidism, there is a table in Harrison which says, descending order, these are the symptoms. Answer is tiredness. Subclinical hypothyroidism, we discussed it, right? Here the TSH, which is hypersensitive, is raised. T4 is normal. See if it is Hashimoto by measuring TPO. Treat if TSH is really high, like greater than 10. Treat if there are symptoms. Okay. Mixed edema coma. Now mixed edema coma, right? Mixed edema coma. Before that, let me go on to the pregnancy and hypothyroidism. So important. Before I specifically mentioning pregnancy and hypothyroidism, I will talk about pregnancy and thyroid. Okay, pregnancy. Let me see. Pregnancy and thyroid. See, most of the thyroid patients are female and also in the reproductive age group, right? So pregnancy and thyroid is important. There are few physiological things you need to know. The first thing is that need is high. I will just write need is high. What does that mean? That means when there is a mother and child and so much of physiological activity going in pregnancy, the sheer amount of T3 and T4 you require is high. Okay, that's understandable, right? The need for T3 and T4 is high. Okay. Second, these are very discrete points, so not it. Second, it's a funny thing we're doing, TSH and beta HCG. Both of them have same alpha unit. Both of them's beta functions overlap a bit. What will happen is that, in simple terms, beta HCG can also go to the TSH receptor and act there. Thyroid will not know. Thyroid will think it is TSH. So, what will happen in condition where there is an increased beta HCG, example, say beta HCG secreting tumor or most commonly pregnancy, there can be this particular action causing increased T3 and T4. Okay. What will happen then? You will get hyperthyroidism. And this is only transient because the beta HCG falls down, right? When it will peak at 8 to 10 weeks. We'll see again this indeed. So there are two MCQs here. Beta HCG peaks at 8 to 10 weeks. So this particular action of beta HCG going and acting on the THS receptor, that is maximum at 8 to 10 weeks. And this condition is called gestational thyrotoxicosis. Okay, that is the second point. Now third point is that what is TPG? Our favorite thyroxine binding globally. The protein with the most affinity for this. Now the TBG is a carrier protein. There is an increased TBG in pregnancy. That means if you measure total T3 or T4 will be increased, but free will be normal. Alright? The free will be normal. These are the three changes in pregnancy you need to clearly understand. And the first one, right, need is high because of the metabolic need is high, T3 and T4. Here, this is the most clinically relevant when it comes to hyperthyroidism. So I was talking about pregnancy and thyroid. Now I'm going to talk about pregnancy and hypothyroidism. In pregnancy and hypothyroidism, you have to make sure a hypothyroid patient, if getting pregnant, is getting adequate thyroid hormones, right? So you should raise even up to 50% of the hormones. Okay, if the patient is taking 100, you might want to go to 150 because the need is high. Increase the thyroid hormone levels. Now, how much to increase? One simple measure, make sure that your IU 2.5, the TSH is at 2.5. Okay, suppress the TSH to a 2.5 level, that's one way. Anyway, just make sure that there is enough thyroid T3 and T4 in circulation, especially when the patient is pregnant. Alright. Another point is that in a pregnant patient, if you measure total T3 or total T4, you might find it high because of the TBG excess, binding hormones are more. So measure the free T3 and T4. Alright. Now we'll take one specific scenario, mixed edema coma. Now mixed edema coma, you will mostly see this patient in a casualty or in the ICU, right? The patient is actually usually an elderly female, non-complaint of the medication. You know what is the most striking thing about mixed edema coma? The mortality is 30%. That too with the treatment. Significant mortality, right? Like 30% mortality with the treatment. 30% mortality. We are talking about 30% mortality. Now there are three hypos you need to know. Hyponatremia, hypoglycemia, hypothermia. Okay, MC, mixed edema coma. There are three mixed edemas in thyroid. Mixed edema coma, the skin appearance mixed edema, and the third one is a pre-tibial mixed edema, which we will see in hyperthyroidism. Okay, now mixed edema coma, heavy mortality. The patient, usually a non-compliant patient, non-case of hypothyroidism, presenting with a stressful factor like sepsis, going into sudden hyponatremia, hypoglycemia, hypothermia, right? The patient is sick and is in the ICU. How do you treat? You treat all of this. And you actually give IV T4 or a mix of T4 and T3. Technically, we want to give T3. Right, usually we only give T4, right? If it is a hypothyroidism treatment, we only give T4. But in this case, we might want to give T3. But practical purpose, we actually give a heavy dose of T4. Okay, almost 500 microgram IV we give. There are reports which say T3 is also beneficial because the peripheral conversion of T4 to T3 will be impaired in this condition, right? So we might as well give T3. And obviously, T3 is faster and shorter acting. Okay, now what is the name of T3? Liothyronine. So in our Q bank, I have seen many people making, almost 50% people making this mistake. T3 is liothyronine. Okay, liothyronine is T3, not T4. So if you get a question, liothyronine is what? T3, T4. You should answer T3. It's such a simple thing, but you know, a lot of mistakes is happening. Right, so coming into mixed edema coma, heavy mortality, 3 hypos, you use IV medications to treat the patient. Okay. Next one. Next specific syndrome is sick euthyroid syndrome. Or I would like to call low T3 syndrome. So this scenario, I'll explain. You have a new first year PG joining, okay, and you are in the ICU. And PG is very aggressive in ordering investigation. You have a very sick patient, he has ordered TFT. Just like CBC has ordered TFT. And you get the TFT back. The patient is, say, admitted with CVA. Okay. And you see that T3 is low. TSH is slightly decreased. T4 is on in the lower range. Oh, the patient already have enough problems. Now you have low T3 also. What is it actually? So this is nothing but the sick euthyroid syndrome, which occurs in patients who are actually sick. What happens is that, you remember deiodinase? Deiodinases does what? They convert T4 to T3, right? So in these sick conditions, there are T3 deiodinases, D1, D2, D3. And you know that D1 and D2 are the guys which will convert T4 to T3. And what does D3 do? D3 converts T4 to reverse T3. D3 converts T4 to reverse T3, right? Now in this condition, there is actually a reduced activity of D2. So the conversion of T4 to T3 is reduced. So T3 is reduced. This is what happens first. So there is decreased T3. Also the D3 guy, which converts T4 to RT3, is not affected. So in this condition, the RT3 will keep accumulating because there is low clearance. So this will cause to increased reverse T3. So the characteristic feature will be low T3, other things normal, and increased reverse T3. Now this is Harrison, and Davidson actually says something different. I would say don't worry about what Davidson says. Okay, so they're given a different picture. I don't know why. So this is very clear. Sick euthyroid, first finding is low T3. Associated finding is increased reverse T3. Affected enzyme is deiodinases, specifically the D2 deiodinases. Average replacement dose of T4. What did I tell? It's like 0.16, right? 0.16 average is 70, comes to 112, right? Which is closed. This is MCG, right? This is MCG. If you are putting in MG, 150 is closest. It's 150 MCG, right? 150 is close. The answer is 0.1. Okay. Usually thyroid levothyroxine, L-troxin tablets are available in 100 MCG is 50, 25. Yeah, you start with 50 to 100, then titrate up or down. So the average replacement dose is 0.15 as per this option, analyzing these options. Okay. Half-life of levothyroxine is discussed. 7 days is the half-life of levothyroxine. As I said, long half-life. If you miss a dose, not a problem. Next day patient can take double dose. Compared to levothyroxine, liothyronine, can you write it down? Liothyronine is T3. I've seen 50% of people making it wrong. I was shocked. Compared to levothyroxine, liothyronine has, I discussed this, right? It has actually a better absorption. It is asked to repeat question. Okay, T3 has a better absorption. Okay. Again, repeat question. We were discussing Hashimoto, right, so far. Thyroid malignancy which develops in patients with Hashimoto's lymphocytosis. If you know the pathology, you can answer, right? There is a swarming army of lymphocytes coming and destroying the thyroid. So I would bet on lymphoma, and that's the correct answer. Lymphoma, Hashimoto. If it is a radiation exposure, papillary. Most common, papillary. Most common with, say, a blood metastasis, follicular, right? All are true about Hashimoto's disease except. Now, this is a pathology question. I will just right away give you the answer. The follicles are lined by basophilic cells with clear cytoplasm. Is wrong. Okay, it has Hurthill cells. It has abundant eosinophilic cytoplasm, which is basically granular. Abundant eosinophilic cytoplasm, which is granular, is the answer. This is wrong. Plasma cells and small lymphocyte infiltration is seen. There is obviously follicular destruction. Well developed germinal centers with increased interstitial connective tissue and Hurthill cells. We discussed that. 23-year-old college girl. Oh. Under medical management for panhypopituitarism after craniopharyngioma resection. she came with a TSH report. The TSH is below limits of detection of the assay. Which of the following is the next most appropriate action? One of the most simplest question you can actually get made complicated, right? The patient had what? Panhypopituitarism. That means the pituitary is gone. There is nothing which is producing pituitary. Fine. You are giving T4. So what is the point in measuring TSH? Anyway, there will not be TSH. You don't expect any TSH because there is a panhypopituitarism, right? So the mistake was from the doctor to measure a TSH, right? Don't measure TSH. Measure T4 because you are giving T4. There is no TSH. So if you want to follow up T4, you measure T4 and follow up. Is it clear? Right. Hypothyroidism due to disease of thyroid gland is associated with increase in plasma level of cholesterol. We discussed this point. There is a decreased clearance. That's why this is increased. Thyroid hormones are needed for the clearance of cholesterol metabolites. But when there is low thyroid hormone, there is decreased clearance, which will result in hypercholesterolemia. Most common presentation of endemic goiter is diffuse goiter. I think we discussed that fact again. It is diffuse goiter. You might not, most cases of an endemic goiter, when there is iodine deficiency, you might not find hypothyroidism. Still, it is basically the diffuse goiter which is active, which is more prevalent. Not found in hypothyroidism. We discussed this, right? We discussed this. Hypo does not mean hypothyroidism. There are two things in hypothyroidism which are over. One is periods and pressure. Okay. You can find menorrhagia and we can find hypertension in hypothyroidism. So the answer is hypotension is not found in hypothyroidism. In fact, you find diastolic hypertension because of the increased peripheral vascular resistance. Okay, I have merged a number of questions here. Cause of hypothyroidism are all except. Do you remember me zooming in that one particular table and discussing? Sarcoidosis, yes, infiltration. Hemochromatosis, yes, infiltration. Autoimmune, that's your Hashimoto. Virus, yes. Lithium, drug, yes. To struma ovary. Kind of a teratoma which produces thyroid hormone elsewhere, right? So it is not going to cause hypothyroidism. Sheehan, yes. Central cause, secondary hypothyroidism. Amyloidosis, yes. Infiltration. Cystinosis, yes. Infiltration. So you could get a question with any of this mix match. Cause of hypothyroidism. So the answer is struma ovary. Everything else can cause hypothyroidism. Patient has low T3, low T4, low TSH. Low T3, low T4. You expect TSH to be high, but it is also low. Her condition cannot be primary hypothyroidism. Had it been primary hypothyroidism, we would have got an increased TSH. Common finding in hypothyroidism. Answer is raised LDL. You can detect this question. Basically, it's not going to be a raised HDL. VLDL, nobody worries about the LDL. Then it's a question about TG and LDL. The answer is raised LDL.